Welcome to Report Back from ASCO on Metastatic Breast Cancer. I'm Ivis Sampaio, Senior Director of Programs at SHARE. Before the presentation begins, I'd like to tell you a bit about SHARE. SHARE is a nonprofit organization that's been helping people with breast and ovarian cancer for the last 42 years by offering the support of those who have been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs. All services are free of charge. For more information, visit our website, sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for a questions and answer session. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember, the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Dr. Mark Robson is the Chief of Breast Medicine at Memorial Sloan Kettering Cancer Center. Dr. Robson is a board-certified medical oncologist that specializes in the identification and management of individuals who have inherited an increased risk for cancer. Dr. Robson focuses on helping both men and women with cancer incorporate their genetic information into their treatment plan. Additionally, Dr. Robson works to develop preventive plans for individuals who have an increased risk of cancer. This plan looks to limit the disease effects if there is an onset of the disease. His overall research focus is to determine the most beneficial way to incorporate genetic information to improve the outcome for those at risk for hereditary cancers. Without further delay, I'm happy to welcome Dr. Mark Robson.
So good afternoon or good morning or whatever time it is where you are, and thank you for the invitation to share some information from ASCO in June. My brief, if you will, is to try to talk a little bit about information that came out of ASCO that specifically pertains to metastatic breast cancer. As you all are probably aware, the biggest breast cancer news at that meeting was really the TAILOR-X study about adjuvant therapy and identifying women who were less likely to benefit from the addition of chemotherapy and hormone therapy. But we're not going to talk about that today. Instead, we're going to spend time focusing on specifically those studies that seemed to be particularly relevant, that concentrated on the treatment of metastatic disease. Now, the first topic that I'd like to talk about is the use of a new class of drugs called CDK4/6 inhibitors in women who have metastatic hormone receptor positive breast cancer. There are 3 different agents that are now approved. The first one is palbociclib, which is also known as Ibrance. And then the other 2 are abemaciclib and ribociclib. Try to make this move forward. Now, they're approved in a somewhat complicated matrix of indications. Palbociclib or Ibrance was the first one and was originally approved for women who had metastatic disease and were actually progressing, usually on an aromatase inhibitor. And the drug in that setting would be given in combination with fulvestrant, also known as Faslodex. But subsequent studies demonstrated benefit in the initial treatment of metastatic breast cancer patients with, in combination with aromatase inhibitor and specifically letrozole. Ribociclib, also known as Kisqali, is approved in the first line, so initial treatment of metastatic disease in combination with an aromatase inhibitor. And then abemaciclib, which is also known as Verzenio, is used either in that setting, initial treatment of metastatic disease, or in the setting of progression after initial treatment, or this is the only drug that actually has an indication as single agent therapy after progression on both endocrine therapy and on chemotherapy. So as you can see, sort of a complicated set of overlapping indications, largely coming about because of different study designs. Now, all of these drugs have really pretty substantial effects, essentially no matter when you use them. This is the series of trials that are already available. And what you can see, I don't know if I have a pointer on my, do I have a pointer? Let me see if this works. So as you can see, this is the median progression-free survival. So that means that 50% of the patients on the different arms reached this amount of time before their disease looked like it was growing. Plaque is the placebo arm. These were all placebo-controlled trials, and this is the active or the investigational agent. And for all of them, there seems to be, roughly a doubling or nearly a doubling of progression-free survival, which is highly statistically significant. Sorry, trying to move forward. Trying to progress this, which is not going so well. So the study that came about at the one of the studies that was presented is a study called Mona Lisa 3. And Mona Lisa 3 was to look at ribociclib plus fulvestrant or Faslodex in women who had metastatic disease with hormone receptor positive metastatic disease. And this was the design. This was upfront therapy or, well, either upfront or one prior line of endocrine therapy. So it was a mixed bag of patients randomized to either receive ribociclib fulvestrant or placebo and fulvestrant, with progression-free survival being the primary endpoint. This is all the statistics, none of which is really tremendously important. And just as we saw in the other studies in this setting, overall, ribociclib did provide a substantial benefit compared to placebo in progression-free survival. Again, just like the other studies, nearly a doubling, but remember, this is a mixture of first-line and second-line therapy with a very substantial prolongation of progression-free survival. This is by investigator assessment, so this is when the doctors who were running the trial took a look, but you got similar results if it was done another way. Now, there was benefit both in first-line therapy, so this is no prior endocrine therapy, and this is in patients who had prior endocrine therapy, all of whom seemed to benefit. So patients getting ribociclib and fulvestrant had statistically significant and a very clinically meaningful improvement in progression-free survival versus placebo and fulvestrant. It was consistent benefit across the subgroups, and it was observed with both first-line and second-line therapy. And so this now is another first or second line treatment option. But, again, if you look at all the other trials and match them all up, it's not really clear that there's a whole lot of difference between the three agents in the different settings. They all have roughly the same degree of benefit. They have slightly different toxicity profiles, which I'll talk about in a second. But fundamentally, I think my take on this is that in the first line setting, the situation with the CDK4/6 inhibitors is very much like the situation with the aromatase inhibitors. We have letrozole, exemestane, and anastrozole all available, and it's not clear that one of those is superior to the other in any particular use case. And I think we're seeing very much the same type of thing with all of the CDK4/6 inhibitors. Now, another study that was presented is a study called Monarch 2, and Monarch 2 is a study of abemaciclib, which is the third, if you will, of the CDK4/6 inhibitors. And the interesting twist on this one is that it was specifically looking at the use in pre or perimenopausal women with hormone receptor positive, HER2 negative advanced breast cancer. The other drugs have been used in pre or perimenopausal women, but this was a very dedicated study to look specifically at the benefit in that group. So pre or perimenopausal or postmenopausal women, because this is a big study looking at all hormonal factors, who are hormone receptor positive metastatic disease, had progressed, so this is now second line therapy, but had not received chemotherapy, were randomized to receive abemaciclib with fulvestrant or placebo with fulvestrant, and if they were pre or perimenopausal, they were given a GnRH agonist, so something like Zoladex or Lupron, to turn off their ovaries. So these women were rendered postmenopausal even if they were technically premenopausal or perimenopausal. And just these curves now are pretty much reproducible for all of the CDK4/6 inhibitors. You had a substantial prolongation in median progression-free survival. This is second-line therapy, so it's not quite as great as it was in the first-line therapies, but nonetheless, very highly statistically significant and quite meaningful from a clinical standpoint. If you look at this at 1 year, roughly 40% of women on the placebo arm are without progression compared to about 65% of the women on the treatment arm. So in terms of delaying the time to progression and need for additional therapy, very highly effective treatment. And specifically in the pre or perimenopausal subset, if anything, an even greater degree of benefit, although the numbers are quite small. But certainly in pre or perimenopausal women with metastatic hormone receptor positive disease, if you both shut off their ovaries, gave them fulvestrant and abemaciclib, you had a pretty substantial degree of benefit, as you can see. Now, the interesting thing about abemaciclib, which is different from palbociclib and ribociclib, is that there's a fairly substantial incidence of diarrhea with abemaciclib. Neutropenia, low white blood counts, these are actually common with all of the CDK4/6 inhibitors, and that's why when you start on the drug, you have to check the blood counts a couple of weeks afterwards to see whether or not doses need to be modified. But diarrhea does seem to be pretty specific to abemaciclib. And it's manageable, with things like Imodium, and particularly if you jump on it early, it doesn't seem to require discontinuation, but nonetheless, it is something that makes it a little bit different from the other drugs. So abemaciclib plus fulvestrant and a GnRH agonist like Zoladex or Lupron significantly improved progression-free survival and actually response rates, shrunk the disease more quickly in patients who had measurable disease. If you were pre or perimenopausal with advanced breast cancer, and it was generally well tolerated. The diarrhea was predictable, started early, and was manageable and reversible, stopped once you stopped the drug. So early intervention is required, though, because otherwise people have a lot of discomfort, and obviously diarrhea is a very unpleasant side effect. So this is now the landscape, if you will, in patients who have progressed after endocrine therapy for metastatic disease. So now in the second-line setting, in general, if you just give somebody fulvestrant alone, the median progression-free survival is somewhere between 4.5 to 9 months. Whereas if you give a CDK4/6 inhibitor, it's particularly in the more recent trials with less heavily pretreated patients, you have 16 to 14 months, 15 to 16 months, which is a fairly substantial benefit for a relatively little degree of incremental toxicity. So that's CDK4/6, and I think that's been the biggest advance so far in hormone receptor positive metastatic breast cancer. Sandpiper was a study that was looking to explore the whole concept of more specifically targeted therapy directed towards particular genetic mutations identified in the tumors, again, of hormone receptor positive patients. There's an enzyme called PI3 kinase, which is very, very important in transmitting signals from outside the cell to inside the cell. And mutations that essentially turn on PI3 kinase, which is called PIK3CA, it's complicated, but the gene name is different than the protein name. But PIK3CA mutations are among the more common mutations in cancer overall. It's not just restricted to breast cancer, but certainly nearly 40% of hormone receptor positive breast cancers have specific mutations in these genes, which lead to activation of hormone receptor signaling and enhanced cell growth. And there are specific inhibitors of PI3 kinase, which have been explored in the clinic for some time. And Sandpiper, it was an investigation of a particular PI3 kinase inhibitor called Topacio, And the randomization here, all women were postmenopausal, all had already progressed after an aromatase inhibitor such as anastrozole or letrozole or exemestane. And if you had a PI3 kinase mutation identified through genomic profiling, you were randomized to either get Topacio plus fulvestrant or placebo plus fulvestrant. And they actually also planned to do an analysis in patients who did not have PI3 kinase mutations identified, just to see whether or not there might potentially be a benefit in that setting. And so the primary purpose of the trial was to look for investigator-assessed progression-free survival in patients who had PI3K mutant tumors. And this is a setting where there was a statistically significant benefit in terms of improvement in progression-free survival, but the median improvement was only 2 months. And as you can see, the curves come together very quickly down after roughly 10 or 11 months, roughly a year. So it looks like there's a little bit of a delay in progression, but that benefit is lost pretty quickly. So although this is certainly in a sense, proof of principle that it does work, I think what happens is tumors unfortunately develop mechanisms very, very quickly to be able to overcome that blockade, and then they just go ahead and don't derive any additional benefit. And the challenge with all of these drugs, Topacio and the other PI3 kinase mutations, is that they're unfortunately quite toxic. The biggest side effects are particularly high blood sugars, and some people even develop diabetes, but there are some other unpleasant side effects as well. And so nearly 50% of the patients getting the Topacio had grade 3 adverse events, which are those that are quite significant. And as you can see, that's a very substantial bump compared to the women who got Faslodex alone. And as a matter of fact, nearly 40% of the patients had to have their dose interrupted to deal with side effects, and 17% of the patients actually came off study because of toxicity. And that, of course, with Faslodex alone is pretty uncommon. Faslodex alone is a very well, or fulvestrant alone is a very well tolerated agent. So this is one of those settings where even though the trial was positive, it unfortunately was not positive enough to overcome the potential increased toxicity. And so what this means for future development of this particular combination remains to be seen. But certainly is not something that we are rushing to apply in the clinic, given the other options, such as the CDK4/6 inhibitors that I showed you earlier. Now, a drug that's perhaps a little bit more exciting or interesting is a drug called sacituzumab govitecan. What a mouthful. But this is what we call an ADC, or an antibody drug conjugate, and I'll explain that in a second. And it has been very aggressively developed actually for triple negative breast cancer. There's been a lot of excitement about benefit from this drug in triple negative disease, but this was a study that was describing potential benefit in patients who had hormone receptor positive disease, so ER positive, HER2 negative disease that was metastatic. And what sacituzumab is it is an antibody that is directed against something called TROP2, which is on the surface. It's a antigen that's on the surface of a lot of different cancers, including metastatic breast cancer. And while this was originally developed for triple negative disease, TROP2 is not restricted to triple negative disease. It's also seen on hormone receptor positive cancers. And this antibody is linked to a drug called SN38, which is a chemotherapy agent that is extremely potent and very, very toxic. As a matter of fact, it's the active metabolite of another drug called irinotecan, which is very commonly used in, for instance, colorectal cancer and to a lesser extent, pancreas cancer. And so SN38 is just so toxic that you can't give it essentially by itself because it causes too many side effects. But if you attach it to this antibody, when the antibody I've been going for a while without anybody there. So the antibody itself attaches to the target TROP2 and then gets pulled into the cell. And inside the cell, this linkage between the SN38 chemotherapy and the antibody gets broken. And now the chemotherapy is essentially delivered directly into the cell without causing too much damage in the surrounding tissues. It's not perfect because this linker can to some extent be broken up even in the circulation. And also if the cell dies and the drug hasn't been metabolized, the drug can be released locally just from cell death. But nonetheless, it certainly is a very effective way of developing it. And there's all kinds of cute military metaphors that have been developed about smart bombs and things like that. There's an anti-HER2 drug called TDM1, which works in very, very similar way. Antibody directed against HER2 linked to a chemotherapy agent. So this is a increasingly common type of agent that we're seeing in the clinic directed against a whole variety of different targets. Anyway, when they first studied this, what they did was called a basket trial. So they took a whole bunch of different patients whose cancers theoretically would express TROP2, and then gave the drug to them and focused on the different subsets essentially on the back end. And 215 of the women, or of the individuals in these basket trials, were breast cancer patients, most of whom were triple negative, and that has been reported at San Antonio. And this is now the 52 patients who have hormone receptor positive disease. This is the treatment schema. Basically, everybody got treatment, so there's no placebo arm here, which means that you don't know whether or not these women might have benefited well from something else. But nonetheless, this is just looking at response rates and outcomes. And this is what's called a waterfall plot. And so everything that is below the line means that the individual's cancer shrunk by this particular percentage. Everything that's above the line means that it grew by this particular percentage. And what you can see is that most of these bars are below the line. And these are for women who got up to 5 prior half of them got 5 or more prior lines of treatment, including 2 or more prior lines of chemotherapy. So these are women who received a lot of therapy for their disease, and yet their overall response rate, the probability of their disease shrinking, was about 30%. And the chance of having some benefit, either shrinkage or stabilization for at least 6 months, was nearly 50%, which is a pretty impressive and quite encouraging result in this heavily pretreated population. And then this is just the progression-free survival curve showing.
Dr. Robson, sorry to interrupt. There was actually a technical glitch on the side of the webinar provider. The audio had started for us, but it didn't start for some of the attendees. Is it possible that you can do like a quick review for those who couldn't hear?
Of what part?
Just the beginning slides, just a quick summing up, just because some of them couldn't hear the audio. It had started for us, but then it didn't start for them. They were on standby mode.
Sure, up to what point?
This covers the 3 trials, the Mona Lisa, the Monarch 2, and the Sandpiper. The Sandpiper and the Paloma.
All right, well, let me go back. Let me finish, and then I'll go back and we'll kind of recap that part for everybody else. Okay?
Thank you so much.
All right, so this is the progression-free survival for the women getting sacituzumab. So clinical activity was good, including actually individuals who had liver metastases. You know, it didn't last forever, but the benefit did last for at least 7.5 months, which is, again, pretty good in this setting. And so there's certainly excitement about moving this drug up earlier and using it in combination with other agents. And then this is going to be the last trial I think I want to talk about, which is something called Topacio. Topacio is interesting because this is now combining 2 approaches which have been quite exciting in the recent past. One is PARP inhibition, and the other is immunotherapy with a checkpoint inhibitor. And so niraparib is a PARP inhibitor, pembrolizumab is a checkpoint inhibitor, and kind of naturally the idea would be to put these together in triple-negative breast cancer to see how well they work. There is some rationale for doing this. If you give a PARP inhibitor, even in the absence of a BRCA mutation, it increases DNA damage, and there is a pathway called the STING-CGAS pathway, which recognizes intracellular DNA fragmentation and generates an immune response, which then in turn activates it generates an inflammatory response, which activates an immune response. And the thought is that this probably developed through evolution in order to help kill cells that had been infected with DNA viruses. And so there's a recognition of abnormal DNA fragments, which then essentially trigger this self-destructive mechanism. So if you triggered increased intracellular DNA damage with the PARP inhibitor, and then essentially released or activated the immune response by inhibiting checkpoints that normally keep that immune response in check or mitigated, then that could be a productive anti-cancer strategy. And so this was a phase 2 study done in both breast cancer patients and in ovarian cancer patients. This is just the breast cancer group, looking at triple-negative disease because it's such an unmet need. Patients who had relatively little prior treatment, so 2 or fewer prior lines of therapy, and giving them niraparib and pembro every 21 days. And what you can see is that you looked at the individuals who had BRCA mutations in their tumors. These may or may not have been patients who were born with BRCA mutations, but they had them in their tumors. 60% of those patients responded. And if they had something called homologous recombination deficiency, which is measured by various different techniques, including actually looking for mutations in other genes, or if they had a BRCA mutation, the response rate was about 55%. PD-L1 is the target for the checkpoint inhibitors, and so in patients who have PD-L1 expression, the response rate was 36%, none of which is magic. It's not the level that we're seeing in certain, for instance, lung cancers or melanoma, but certainly is an interesting response rate and better than that has been seen in other immunotherapy trials, particularly late-stage triple-negative disease. And this is another one of those waterfall plots, and as you can see here, unlike the situation with sacituzumab, it's not 100% or it's not a huge number of patients responding, but certainly there are good responses, and some of these people even had complete responses. In other words, everything went away, and some of these are durable, which are indicated by the arrows, which means they're continuing. So this is just another indication of ways to try to make immunotherapy better in breast cancer. As unfortunately with all the other therapies in this setting, it didn't necessarily work for as long as we would like, but median was 8 months for the patients who had mutations in BRCA in their tumors. And just as a comparison, the median progression-free survival for instance, olaparib or talazoparib in patients who have BRCA mutations, so PARP inhibitor therapy alone, is somewhere around 7 to 8 months. So this is not dissimilar from what you might see in a PARP inhibitor therapy, but these are more heavily pretreated patients. So that is what I had to say about the trials. Let me go back up to the beginning if you all want to close your eyes, because I'm going to skim through and don't want to make anybody nauseated. So I think what I was saying at the beginning is that the biggest advance I think we've seen in metastatic breast cancer, particularly hormone receptor positive breast cancer so far, has been the CDK4/6 inhibitors. And these are just a summary of all the trials that have been so far done in first-line setting. So this is initial therapy of metastatic disease. Across the board, there's roughly been a doubling of progression-free survival compared to placebo Most of these are in comparison to aromatase inhibitors, or compared to aromatase inhibitors plus a CDK4/6 inhibitor. MONALEESA 3 was a study that was done to look at a new CDK4/6 inhibitor, or a third CDK4/6 inhibitor called ribociclib plus fulvestrant or Faslodex in postmenopausal women now. And these are patients who either had received no prior therapy or had received one prior line of therapy. Randomization, ribociclib plus fulvestrant versus placebo. And there was benefit, a benefit very similar to what's been seen before. First line therapy benefited. Again, median progression-free survival in this setting had not even been reached, but it looked like it was nearly a doubling of the placebo benefit. And then in second line therapy, exactly what we've seen with the other trials. So this is just, unfortunately, one more drug. And so it's challenging for us to pick out a winner here among palbociclib, ribociclib, or abemaciclib in the setting of metastatic disease with first-line treatment. MONARCH 2 was the other study that was looking at CDK4/6 inhibition. This is with abemaciclib, and it was specifically, this was another study that included both pre- and postmenopausal women, but this was an analysis specifically of the pre- or perimenopausal set. So these were women who had either progressed or early relapse, no more than one prior therapy. But if they're pre- or postmenopausal, they got abemaciclib plus fulvestrant plus a GnRH agonist, so something like goserelin or Zoladex or Lupron, which is Luprolide, something to turn off their ovaries, if you will, and render them postmenopausal, compared to placebo plus ovarian suppression. And these curves now are becoming sort of familiar. I don't think we should ever be blasé about it, because these are really good results. Nearly a doubling of progression-free survival in the patients getting the CDK4/6 inhibitor plus fulvestrant plus ovarian suppression in this particular setting. So the first trial, this is all comers in terms of both pre- and postmenopausal women, and this is just pre- or perimenopausal women alone. So the benefits of this particular agent don't have to be restricted, if you will, to women who are postmenopausal. Women who are premenopausal at the time of their metastatic disease can also derive benefit from this approach. But abemaciclib, as I was mentioning at the beginning, does have some additional toxicity, and in particular, its additional toxicity is diarrhea, which is manageable with antidiarrheals, but obviously an uncomfortable and potentially problematic side effect. So then this is now the landscape in patients after progressing after endocrine therapy. So you have the original Paloma 3 studies, and then MONARCH 2 and MONALEESA 3 were the two that were reported here at ASCO with very, very similar results. Progression after first-line therapy, so this is now second-line treatment for metastatic disease, nearly a doubling of progression-free survival, nearly 16 months median. Sandpiper was a study looking at PI3 kinase inhibition. This is targeted therapy directed towards tumors that have mutations in the PI3 kinase gene, or PIK3CA gene, which activates a pathway that leads to increased estrogen receptor signaling. These mutations are relatively common, about 40% of hormone receptor positive breast cancer. And the idea would be, if you could inhibit PI3 kinase, that you could basically turn off or reduce the activity of this pathway. And so this is a trial of a drug called Topacio combined with fulvestrant or Faslodex, compared to placebo plus fulvestrant in 480 women who had PI3 kinase mutations and another 120 women who were agnostic, who did not have PI3 kinase mutations, to see if there was any benefit there. And this is the result, which is a very modest prolongation in progression-free survival, which gets lost essentially by about 10 or 11 months. And so although the drug does seem to work initially, I think unfortunately what happens is the pathway reactivates through other mechanisms. And so even though you're inhibiting PI3 kinase, excuse me, other stuff kicks in to basically overcome that and continue to drive the pathway. And that then causes you to lose benefit. And this particular drug is relatively toxic. I was pointing out that nearly 50% of patients had grade 3 adverse events. Remember, this is on a scale of 1 to 5, so grade 3 is considered to be a clinically significant adverse event. And of course, there were many fewer such events in the patients getting Faslodex or fulvestrant alone. And in terms of dose discontinuation, so coming off study or having to hold their drug for a while, much more common in the patients receiving Topacio than it was in patients receiving placebo. Fulvestrant alone is a quite well tolerated therapy by most women, and so the rates of discontinuation are less than one, or around 1 in 40. But unfortunately, it was considerably higher than that, requiring discontinuation of the Topacio in the study. So while Sandpiper met its primary endpoint, and the addition of Topacio to fulvestrant did show a statistically significant improvement, means that we can hit the target. I'm just not sure that the benefit is great enough to warrant the toxicity, and it's not, unfortunately, long-lasting enough to potentially warrant the toxicity. So I'm not sure what the development pathway is going to be from here with this particular drug, and perhaps other agents might be better tolerated. So did we get through, I think, did they kick in when we were talking about sacituzumab? Hello?
They kicked in maybe halfway through that.
You may want to cover that.
Want me to just show it? All right, so sacituzumab is what we call an antibody drug conjugate, or an ADC, that's been very heavily developed in triple negative disease. It is an antibody that's directed against something called TROP2, which is present on the surface of many different cancer cells, including both hormone receptor positive and hormone receptor negative metastatic breast cancer. The antibody is tied to something called SN38, which is a very potent chemotherapy agent that if you tried to give it by vein would wind up causing unacceptable toxicity. But when it's linked to the antibody, it gets delivered essentially directly into the cell, and once in the cell, the linker is cleaved and the chemotherapy is released just directly where it's needed. And so you can get a very high concentration of chemotherapy within the cancer cells themselves with a much lower concentration in the rest of the body, which at least theoretically mitigates some of the toxicity. So the original studies of sacituzumab were being done in a basket trial approach. So patients who had epithelial cancer had failed at least one standard regimen for their disease, and breast was the greatest representation in this trial, and in particular triple negative disease, which was being reported at San Antonio. And then this is now a subset of patients who had hormone receptor positive disease. Given this drug on day 1 and day 8 every 21 days, and this is the waterfall plot just illustrating that nearly half of the patients derived some degree of clinical benefit from the treatment. 30% of the patients had shrinkage. This was despite the fact that they had received a median of 5 prior lines of therapy for their cancer, including a median of 2 prior chemotherapy lines. So this is not something that apparently is only beneficial for patients who have triple negative cancer. It looks like it can potentially also be a benefit for women who have hormone receptor positive disease after they have received some chemotherapy. And this is the progression-free survival curve, which of course is not great. We'd love to have longer progression-free survivals, but for patients who have received the degree of prior therapy that these patients had received, this is certainly an encouraging advance to build upon. So there are a lot of additional studies being done with sacituzumab, looking at combinations with other agents, both in breast cancer and in other cancers, to try to improve outcomes. So I think we're going to be seeing this drug incorporated into breast cancer treatment, hopefully relatively soon. All right, so I think that's where I wound up, right? So thank you again.
Okay, Dr. Robson, we have a few questions here for you, but first I want to thank you so much for being able to cover this twice, no less, and I guess that helped us to understand things better. There are quite a few questions here, but many of them you did actually answer. So let's start with, is there any new advancements for HER2 breast cancer with metastasis to the brain?
I don't think there's anything, unfortunately, new. Certainly people are looking at the benefits of different kinds of combinations, but there is no specifically new approach for brain metastasis.
Okay, so next is what treatments look hopeful if the aromatase inhibitors and the CDK4/6 fail for ER/PR patients?
There's a lot of, well, so we talked about sacituzumab, which is kind of certainly very interesting. There's also certainly work that's still going on with fulvestrant and everolimus, what used to be called Afinitor, or is called Afinitor, those kinds of combinations. And then we're looking at targeted therapies. The PI3 kinase inhibitors do not, at least so far, have not fulfilled their promise. But there are other targeted therapies, AKT inhibitors and the like, that kind of attack that same pathway that are of interest. And then, of course, there is immunotherapy. People are starting to do trials with immunotherapy in hormone receptor positive disease. Although so far it kind of looks like most of the benefit is, well, at least if there is benefit, it looks like it's likely to be early in triple negative disease. But certainly people are going to investigate hormone receptor positive disease a little bit more aggressively. So I think there's a number of avenues that need to continue to be explored. And people are certainly working to do so.
One other question is there any way a patient can classify their subtype of triple negative breast cancer with a pathology report?
Probably not with a pathology report. It usually requires some additional testing to be performed, and there's a number of different ways of doing that. Some assays are commercial, some are not. The only possible exception is that there's a subset of triple negative breast cancers which overexpress something called androgen receptor, and that is a not uncommon subset of triple negative disease. You can do androgen receptor staining just like you do estrogen receptor staining or HER2 staining, and so at institutions that do that, that information may be on the path report. In terms of basal versus Claudin low versus other types, that information really requires additional testing.
Thank you. And I just received one. Were there any important updates for the triple positive metastatic breast cancer?
Yeah, I didn't really go too far into the HER2 side. I mean, I think the big discussion in the HER2 space was a trial called Persephone, which was in the adjuvant setting, a trial of 12 versus 6 months of Herceptin as post-surgical treatment. And that trial reported that 6 months did not appear to be inferior than 12 months of therapy. But there have been 2 other trials looking at shorter durations of anti-HER2 therapy in that setting, which were negative in the sense that shorter therapy did appear to be inferior. And so I'm not sure that the Persephone is necessarily going to lead to a full-scale change in treatment approach, at least not in the United States. It may in some other countries. But from the hormone receptor status, no. I mean, I think the main things would be directed towards a HER2 therapy in that setting.
Okay, thank you. Another question is, are there newer treatments available for metastatic lobular breast cancer?
Well, metastatic lobular breast cancers are usually estrogen receptor positive. And so the approach to them is generally that which is taken towards estrogen receptor positive breast cancers in general. So there's not a specific treatment paradigm for lobular cancer that is distinct from the treatment paradigms that come about because of hormone receptor positivity, negativity, or HER2 expression.
Okay, and someone's asking, how should one decide between CDK inhibitors or chemotherapy?
Well, I mean, this is a situation where it kind of depends a little bit on individual circumstance in terms of how much prior hormone therapy has one gotten, because if it's first-line therapy or if it's even second-line therapy, it looks like the CDK4/6 inhibitors are quite active. I think that if one has received many prior treatments, particularly many prior hormone treatments for estrogen receptor positive disease. There is one study showing that abemaciclib does have some activity in that setting, but the activity of abemaciclib in that setting is quite similar to the activity of many of the other chemotherapy agents. So if it's non-first or second line, it's a little bit hard to point to a lot of data comparing the two. But if it's first or second line, I think most people would go with the CDK4/6 inhibitors at this point, just because the toxicity profile is favorable and the benefits are quite impressive for people who do have response.
Thank you. Someone else is asking, what is the number of segmented neutrophils at which you should take before you stop taking a drug like Ibrance?
Yeah, generally we do it on absolute numbers, not percentages. And usually you can manage the leukopenia and the neutropenia by dose reduction. And so if you have a low count, if your neutrophil count is less than 1,000, then generally what will happen is we will just decrease the dose to the next level. And after that, after one or two dose reductions, most people are able to tolerate the drug.
Thank you. Someone's asking, are there any clinical trials underway for CRISPR gene therapy?
Not that I'm aware of. I mean, I think the thing about CRISPR is that everybody's been very excited about it as a modifier of stem cells, be they embryos or be they some other form of stem cell. Some of that excitement is starting to, I wouldn't say fade, but I think that we're becoming aware that CRISPR is not as accurate as we had hoped it would be, in the sense that it does sometimes introduce mutations that are different, and sometimes doesn't hit what you wanted it to hit. So while it's a very exciting technology for the laboratory, I'm not sure how we're going to be deploying it in the clinic. The other problem in an adult organism, of course, is getting the CRISPR into the cells where you want it to get. I mean, this has always been the problem with gene therapy in adult organisms. It's very difficult to get the silver bullet into the place where you want it to be.
Thank you.
So I think CRISPR will be a future development.
Okay, and I have another question here. Is an increase in CA27-29 levels after year on phosphodex a cause for concern?
Tracking tumor markers to assess response and disease status is always challenging. As a matter of fact, some of the professional societies suggest not doing it because while rising markers can be an indicator that something is growing, it may be a very little amount of something, and if everything else is benefiting, you wouldn't want to change therapy unless there was some change on the scan that would tell you enough disease was growing that it was worth abandoning something that might well be working great for a lot of the tumor cells. So while rising markers are certainly something that gives one pause, it's a difficult thing to act on by itself.
Okay, and is the length of remission a significant factor in the aggressiveness of the cancer?
Our general observation is that people who have a long duration between initial diagnosis and recurrence, particularly for hormone receptor positive disease, tends to have longer durations of response to initial manipulations, whatever they would be, particularly hormone therapy. I mean, those cells tend to be relatively slow growing, and so whatever treatment you give, if it works, tends to hold things in check for a longer period of time. Somebody who has, for instance, metastatic disease at the time of their initial diagnosis. That said, it's always a general observation that may not necessarily be true in specific cases.
Thank you. And someone is asking, is Floral infusion without metastasis to the lungs normal?
Well, clearly not normal, but certainly is something that we see sometimes. I mean, you know, the pleural space is a different metastatic site than the lung parenchyma itself, and so we certainly do see pleural effusions without seeing any disease within the lung proper.
And hi, Dr. Robson, there has recently been some news about Dr. Rosenberg at the NIH about how some of his patients who are suffering from metastatic breast cancer no longer have any signs of disease. Can you explain maybe a little bit about what's being done there?
You know, I think they're doing a cellular therapy, which is quite similar to the CAR T type of stuff that's been done for for instance, certain types of leukemias. So basically, they're engineering the patient's own T cells with a particular guide target, if you will. It was a wonderful outcome, but it's an extremely challenging process technologically, and my understanding is that they have a pretty long wait list at this point. So I think it was a great proof of principle experiment that this is something that at least can work in certain individuals, but making that a technology that is both reproducibly effective and widely available is going to be, unfortunately, a time-consuming process.
Okay, my last question here. Someone's asking about their original breast cancer diagnosis was ER positive, HER2 negative, and then a secondary tumor is barely ER positive. It's PR negative and HER2 negative. Does that make the secondary tumor triple negative?
Yeah, I think probably so. Or you know, we do see evolution, if you will, of the hormone receptor status with time. I mean, cancer cells, if you think of it, the estrogen receptor indicates that the cancer cell perhaps has some degree of requirement for estrogen as a fertilizer. As cancers progress, they unfortunately sometimes lose that requirement. They no longer need estrogen as a fertilizer. If they don't need estrogen as a fertilizer, they don't need the estrogen receptor, and so they often throw it out. But you know, we do see that in a certain proportion of cases, and it means that anti-estrogen directed therapies are unlikely to be particularly helpful in a setting like that.
Thank you. I'd like to thank Dr. Robson for an informative program, and I'd like to thank all of you for both your patience and also for participating. Once again, Dr. Robson, thank you so very much for your patience and for all the information that you've been able to provide. Please take a moment to fill out the survey at the end of this webinar. It may take a minute for the survey to download.
Thank you again for joining our webinar. As soon, I would say within a week, the webinar would be posted, even though it wasn't showing audio on your end, it was recording on our end, so hopefully we can have it up for you guys within the week. All right, thank you again, Dr. Robson.
Thank you.